This next session of the presentation will review glenohumeral instability and associated conditions. First off, we'll start by looking at Bankart lesions, which occur essentially are a result of an avulsion of the anterior inferior glenoid and usually result from a shoulder dislocation injury, specifically an anterior shoulder dislocation. The differential diagnosis for Bankart lesion is quite broad and includes several chondrolabral pathologies such as the OPSA, GLAD, Perthes, SLAP lesions, as well as rotator cuff tears. GLAD lesion is a glenoid labral reticular defect. The OPSA lesion is an anterior labral periosteal sleeve avulsion, and the Perthes lesion is a labral ligamentous avulsion, similar to a Bankart, but essentially with the medially stripped but intact periosteum. It's beyond the scope of this talk to go into details of all of these, but these are essentially things that can mimic or be similar to a Bankart lesion. On exam, most patients with a Bankart lesion will present acutely with signs of with an acute dislocation or instability findings. Typical apprehension, relocation test being positive. In more chronic situations, you can see things like your sulcus sign and your load and shift test being positive. Fairly recent test called the internal rotation resistance strength test is also a quite useful test to help rule in or rule out an internal injury in patients presenting with impingement signs. And so I would suggest having a look at the test, how it's performed, and how to evaluate that. Labral tests, which are generally quite poor tests in terms of sensitivity, can be helpful in a good clinical context. And so things such as your load and shift, your crank test, O'Brien's, etc., may be positive. I personally like the dynamic labral shear test, and I find it to be quite useful, especially if a clunk and pain is reproduced. In terms of investigations, X-rays may be helpful to rule out any bony pathology like a bony Bankart. Obviously, in the context of a dislocation, you may also look for a Cossacks Lesion. And then the MRI, specifically MR arthrogram, is your best modality to assess the glenoid labrum and for Bankart lesions. The management for Bankart lesion is usually conservative initially, unless other indications are present for surgical management based on the inciting injury. So if there's instability concerns, obviously surgical management may be considered in those patients. A close relative of the Bankart lesion is the Cossacks lesion, which is a chondral impaction injury of the posterior superior humeral head upon impaction with the glenoid labrum. So typically with the anterior dislocation, as the humeral head dislocates, you may get a Bankart lesion and also a Cossacks lesion. And both of these are fairly commonly seen in the context of an anterior dislocation. And that kind of leads to the next point, which is the mechanism of injury being essentially a shoulder dislocation or subluxation. Cossacks lesions are present in about 80% of all traumatic dislocations, and to a lesser degree in subluxations. The differential diagnosis for a Cossacks lesion is the same for a shoulder dislocation or chondrolabral pathology, as previously discussed. Similarly, with the Bankart, in the acute setting, the patient will present with signs and symptoms of a shoulder dislocation or subluxation. X-rays are helpful to assess these lesions. The Stryker view probably gives you the best view of the Cossacks lesion. And no treatment is typically required for these defects. They usually are small, and more importantly, they don't tend to engage with the glenoid. But when they do engage with the glenoid, surgical management is necessary to address instability, and that may include a procedure such as the remplissage procedure. You can think of an engaging Cossacks lesion quite simply as one where the posterior humeral defect essentially engages or is in contact with the glenoid. A more specific way to look at it is to think of where the lesion is when the shoulder is in a position of function or in abduction and external rotation. If you look to the picture to the right in white on the top of the screen there, You can see the areas marked in dark gray. When the shoulder is in an abducted externally rotated position, if the defect lines up is oriented parallel to the anterior glenoid, this is what leads to an engaging Cossacks lesion and one that is unstable. An anterior glenohumeral dislocation is the main cause of a lot of the aforementioned conditions on the prior few slides. The shoulder is the most commonly dislocated body joint in the body, and the anterior dislocation is the most common variety. As you've seen prior, the possibility of multiple associated injuries that can occur from this mechanism. GH dislocations have a very high recurrence rates, and some stats range from between 50 to 90% recurrence rates. The mechanism of injury is essentially an anteriorly directed force on the shoulder that is abducted, externally rotated and extended. The differential diagnosis would be a posterior inferior dislocation on patients with multidirectional instability. On exam, acutely, you would typically see a prominent humeral head or a hollow space inferior to the acromion. Post-acutely, you would expect to find some of your positive instability test or positive labral test. Investigations that are useful would be an X-ray, potentially at the time of dislocation if available, prior to relocation, or post-relocation X-ray views to assess for any bony, Bankart, or Cossacks lesions. If there's concern about a large Cossacks or Bankart lesion, a CT scan can further assess any degree of bone loss or bone injury, and then an MR or MR arthrogram can be used to assess soft tissue pathology. The management of anterior glenohumeral dislocation is to try to relocate the shoulder as soon as possible. There's multiple ways to try to do these. Techniques more recently, such as the Cunningham technique. You can in Emerge, you can do traction techniques. This is essentially a long list of options to try to reduce the shoulder. So it's important to get comfortable with one or two approaches and have that in your tool bag if needed. Post relocation, if X-rays haven't been done, or even if they have, you want to get relocation views again to assess for any bony injury. Most patients will be put into a sling after this for comfort, and sometimes with a thought to help stabilize the reduction. There's some controversy as to whether or not a sling or an external rotation sling is better. I think the evidence is not quite clear-cut on this, and so most people probably will still use a sling just because it's a bit easier and perhaps a bit more comfortable. Physiotherapy is useful to work on dynamic stabilizers and to get strength and proprioceptive normalization back into the shoulder. And you can consider surgical consults in high-risk patients, or in recurrent injury situations. I'll move on to posterior glenohumeral dislocations, which are quite rare overall. And the stats would suggest count for about 2 to 5% of all shoulder dislocations. They tend to be commonly missed as well, so it's important to keep an index of suspicion for these, especially with a good mechanism, which is typically an axial load on an adducted, internally rotated arm, or a patient coming in post a violent muscle contraction like a seizure or electric shock. The differential again for this is anterior dislocation, again, multidirectional instability patient. On exam, patients would present with the prominent posterior shoulder. So if you compare the affected side to the contralateral, there will be a prominence at the posterior aspect of the shoulder and the acromion. And they usually have quite decreased range of movement and external rotation, and a lot of pain with any attempt of flexion, adduction, and internal rotation. Again, X-rays are helpful potentially, but not very reliable. The light bulb sign has been discussed as a way to try to assess for these on X-rays. The axillary view is best, but that can be difficult for patients to get into position for these sometimes. And so you may want to consider another view called the Velpo view if the patient is not able to abduct sufficiently. Similarly to an anterior dislocation, CT scan can help assess bone loss, and then MRI or arthrogram to look at soft tissue pathology. Again, you want to reduce these as soon as possible, and then the patient should be immobilized in an external rotation sling for about 4 to 6 weeks. Some of the literature suggests immobilizing in about 10 to 20 degrees of external rotation with the elbow at this side. And then around the 6-week mark, they can begin therapy with similar goals as mentioned for anterior dislocations. Again, patients with recurrent instability or persistent pain may require surgical management. We'll end off the instability component here by talking about multidirectional instability, which involves at least 2 directions of instability: anterior, posterior, and inferior. It's typically atraumatic and often associated with generalized ligamentous laxity. There is, again, not really a clear mechanism of injury in this group of patients, but suggested that essentially there's a history of multiple micro trauma, especially in overhead athletes, that leads to this condition, or they may be just patients with generalized ligamentous laxity. The differential for this is any unidirectional instability, so posterior, anterior instability issues. Positive clinical tests in these patients include things such as your sulcus sign, your load and shift maneuver, your apprehension relocation signs, and if they have generalized ligamentous laxity, they will typically have a high Bateman score, usually greater than 4 out of 9. And if you're not aware, the Bateman score is just a scoring system used to assess for signs of generalized ligamentous laxity, and I would recommend having a look into the different components of the score. Investigations for this condition are similar to those previous, and management most of the time for these patients is to focus on therapy, again, proprioception training, dynamic stabilizer strengthening. Surgery may be considered if conservative management fails, but given that most of these patients don't have any significant structural pathology, surgical management tends to lead to poor outcomes, especially in those with underlying generalized ligamentous laxity. And finally, we'll end up the talk with other things to consider when a patient presents with shoulder pain. So not all shoulder pain originates from the shoulder, and it's important and useful to consider other sources of pain that may refer to the shoulder, specifically your cervical or thoracic spine, where the joints commonly refer to the shoulder girdle. So you want to ask these patients about any neck or upper back pain and assess these areas as indicated. Myofascial structures can also cause referred pain to the shoulder, so you may look for trigger points in the neck and shoulder muscles, such as your trapezius, your rhomboids, levator scap, etc. And the management for these conditions would involve injections, dry needling techniques, soft tissue techniques to help manage and resolve the trigger points in the myofascial pain. Finally, you want to think about neural structures that may refer to the shoulder, so you can assess these usually with the upper limb neurotension tests. And for those patients, nerve stretching or flossing techniques can be helpful, as well as addressing any underlying pathologies such as cervical disc disease or thoracic outlet issues, etc. That concludes our talk. Hopefully this has been a good tool and a good introduction to some of the common pathologies that you may see around the shoulder in supporting exercise medicine. Thank you for